Hi, I'm Dr. Carina Kugelmas, and I'm a pediatric nutrition specialist at Denver Health Medical Center in Denver. And I have the pleasure of having with us today Dr. Michael Schilsky, who's the medical director of liver transplantation at Yale New Haven Hospital and a leading expert in Wilson's disease. And today we are going to talk about, of course, Wilson's disease. So welcome and thank you for being with us here today. So just to kind of start us off, we're going to talk a little bit about if you were to get a call about a teenager who has presented in acute liver failure. And some workup has been done so far and has some normal viral and autoimmune markers. What are some of the things that would prompt you to raise suspicion for Wilson's disease?
Well, thank you, Carina, for the introduction and for the questions today. When we look at the acute liver failure presentation in Wilson's disease, this is something that affects about 5% of our patients, whereas 95% will have a more chronic presentation. But the importance of recognizing it first as Wilson's disease is twofold. One is the opportunity to initiate potentially some disease-specific treatments. And then the second is the importance that this is an autosomal recessive disorder. And once we identify this as Wilson's disease, we have the opportunity to prevent such a severe presentation from occurring in family members. And so I think that's an important take-home message. But getting back to your patient, it's important for us to look for certain specific signs and symptoms that may clue us in as to this might being Wilson's disease. And one of the things we often see in association with acute liver failure is a non-immune hemolytic anemia. So if the patient presents with a low hemoglobin and a high bilirubin that is mostly indirect, that kind of suggests that there is some degree of hemolysis going on, and that can be confirmed on a smear and then looking at retic counts as well. And it's important to do a Coombs test and show that that's negative and not an immune-mediated hemolysis that you treat otherwise. Now, I have seen instances where people have focused on that being the only presence of sign or problem in a patient and forgotten to do an INR. And they may, in these people with Wilson's disease, when they go into these crises where they have acute liver failure, the aminotransferases do not hit the high levels that we often see in the viral hepatitis patients. And so when they're only in a couple hundred or so, people often underestimate the degree of injury, and having that INR in concert with the aminotransferases really does help. There are a few other tip-offs. Interestingly, the alkaline phosphatase, which is a zinc-dependent enzyme, goes down sequentially over time in these patients with acute liver failure. So when we see a cholestatic disease, we see a in concert elevation of both the alkaline phosphatase and the bilirubin. But in these patients, you actually see over time a reduction as the patient is getting worse and worse. It's a paradoxical thing and we don't understand completely, but it is a nice way of actually identifying. And another tip-off that we're finding more often now is actually looking at the ALT, and you may see ALT being extremely low in a number of these individuals relative to the degree of injury, again, for what's going on within the liver. So those are some of the common things we look at. The other things that when you want to get a little bit more specific are the copper tests, but these are some things that we don't get back instantly. And those we would look for the serum copper, which in this setting is often above 200 micrograms per deciliter, twice the normal level of that. One of the things that's less useful in the setting of acute liver failure is actually measuring ceruloplasmin, which is normally low in 95% of patients with chronic presentations. But in the acute liver failure setting, because this is both an acute phase protein and some of the other parameters of things that are going on, we actually find this to be less discriminating than other tests. If you have available a very good genetics unit, they can actually produce gene sequencing in the ATP7B in relative short order as well. But this is something that we typically throw in the background and wait for it to come back while we deal with the other things. The other things that we have to remember is look for the signs and symptoms that will be more specific for Wilson's disease. So if there is a history of mood disorder, if there's a history of neurologic abnormalities, and if we're looking clinically at the patient, we look for Kaiser-Fleischer rings, the copper deposition and decimase membrane of the cornea, recognizing that'll only be present in about 50% of the patients with the liver presentations of the disease. So if it's there, it's helpful. If it's not there, it's challenging. But often it's very hard to get your ophthalmologist to come down to the emergency room and do a slit lamp exam. So we often fly by the seat of our pants on that one a little bit.
There's a pretty wide age of presentation, right, of Wilson disease. And is this common that a teenager would go undiagnosed and just present in acute liver failure like this? Or?
Yeah, the spectrum of diagnosis of Wilson disease goes nowadays even to in utero diagnosis using molecular genetic testing for the mutations of the Wilson disease gene ATP7B, all the way up to patients in their early 70s that have been reported to present. So the phenotype is extremely wide. But however, there are patterns, and the patterns typically run that the earliest damage is occurring within the liver, and because that's the underlying basis is the reduction in biliary copper excretion, and therefore you have a progressive increase of copper in the liver that exceeds the capacity of the liver to fight off the oxidative damage. And so over time, you then have progressive inflammation, fibrosis, and cirrhosis if you're having the chronic presentation versus those who have this sudden drop in the ability to fight that off. And those are the minority that present with acute liver failure. But somewhere along the line, typically later in the second decade of life to the third decade of life, you have this saturation that occurs in the liver and then the spillage back into the circulation of excess bioavailable copper, which then becomes deposited in other tissues in the body. And most prominently, we think of the central nervous system as a site of involvement. And here we will see development of mood disorders anyway, all the way up to frank psychosis in individuals. And in neurologic disease, often you may see tremors and other problems with dysarthria, drooling, and eventually coordination problems and things that mimic Parkinsonism. So these are the earliest signs. But when we get back to the teenage group, often what is found, if you look retrospectively, is a little bit of a history that patient who had been maybe a good student in school was suddenly having problems and their grades were failing down or their interpersonal relationships were falling apart. And that may give you a clue that there may be a mood disorder present in addition to the problems going on in the liver.
So for the general pediatrician out there, sounds like if you have some unexplained mood disorders in a child or neurologic symptoms, to always keep Wilson disease in the back of your mind as something that
absolutely
could be going on.
Yeah, the majority for our pediatric colleagues is seeing unexplained liver disease, and that is probably the highest percent of how patients will present. But absolutely, once you hit the category of people who have abnormal liver tests or findings, and then concurrent symptoms, neuropsychiatric, though it's a must to exclude it.
And does the age of the variability of age of presentation also depend at all on sort of different mutations of the gene or penetrance, or how much does the diet or environmental exposures play a role in any of that?
Well, there hasn't been a really good ability to do genotype-phenotype correlation in most cases. There's over 500 different mutations, with only one being most dominant in North America and present in only 1/3 of patients. And so most people are compound heterozygous, and there's various different type of mutations. There is a hypothesis that some of or a higher frequency of patients with acute liver failure may have the deletions or lack of actual functional protein altogether, whereas there may be milder mutations that have partial functionality that may lead to a later presentation. However, when it's panned out, when you do very large studies to the degree that one can, in a rare disease, nobody's been really able to link them together at this current time. And there isn't very easily available testing which can predict what a mutation will actually do phenotypically in terms of its functionality. So that is a challenge. There are some experimental models trying to look for that, where it's coupled to various different proteins that have utilized copper and what we call peroxidase capacity. So their reactions linked to the ability of iron to be transferred through the copper-dependent proteins. However, these are challenging, and they haven't covered the whole lot of the mutations as yet. So that remains to be developed. So at the current time, we're looking for 2 mutations. We believe there's a very high penetrance in the disease. However, there is a little bit of a disparity in that when we say that, we know that we're not treating all the patients that theoretically are present based on a 1 in 30,000 prediction for this in populations. Although there were some interesting studies in England where they actually went and did population checks, where they have the ability, using the national records, to not only correlate a diagnosis listed for Wilson's, but go and look in the pharmacy and look in other records and see that they're actually being treated. And it does come up around 1 in 30,000. That said, when you just look at the potential for genetic mutations in different populations, there have been different calculations showing as frequent the mutation presence of being 1 in about 8,000 or so. But yet we see in the population at large about 1 in 30,000. So some people believe that disparity may have to do with penetrance. I think it's maybe more our lack of understanding of what some of these mutations may be.
So, and we know that copper accumulation affects, we talked about the brain, and are there other extrahepatic organs that are affected from the copper accumulation as well? And ophthalmic, but
Sure. There's actually a wonderful figure that we put in the New England Journal. Dr. Eve Roberts and I put together a review for that a couple of years ago. And actually, to our credit, Eve's credit especially, the figure actually was one of a woman and not just of a man, always, as we see in the journals.
I like that.
But we did highlight that there are a lot of other extrahepatic manifestations that can occur, everything from the Fanconi's anemia, that Fanconi's changes in the kidney that may lead to other proteinurias, and there can be effects on bone density with a premature osteopenia, osteoporosis. There can be effects on some of the endocrine glands and on bones. But, the majority of what we see clinically as relevant is mostly focused on the central nervous system. Hemolysis, actually, that's another example. And actually, indeed, not all bouts of hemolytic anemia are associated with acute liver failure, and some patients will have these intermittent bouts of hemolytic anemia that go unrecognized as being associated with that until people start to think of looking and putting it together.
Mm-hmm. And what is the main cause then of, not in the setting of acute liver failure, why do you have the non-immune hemolytic anemia?
We think it's still associated with the buildup of copper in the circulation that affects eventually the red cell membranes and leads to the hemolysis. We don't know what the tipping point is for these individuals. Why are they more susceptible than are others who may not have that? Because again, this is not present so frequently. But we do know that when we go back historically and look in a number of these patients, it's clearly been there and reported.
So if this patient had presented earlier, not in liver failure, but maybe, was a part of a workup for metabolic associated steatotic liver disease and had would that be a good opportunity to order the ceruloplasmin and 24-hour urine copper
Sure.
if that had been abnormal? Or at what point does the ceruloplasmin make you concerned for is there a magic cutoff?
No magic cutoffs, but I think it's just the diagnostic accuracy is higher when you have it outside the setting of acute liver failure. Although if you look at that as a single factor for predictor of disease diagnosis, it's often low in terms of using it as a sole factor. And part of that is because there's other circumstances where we may see a low ceruloplasmin. Other patients with significant hepatic insufficiency due to other liver injuries often may have a low level. And this is something that sometimes we can pick up if we look at other pathways like the iron binding capacity in the serum. If that's very low in concert with the ceruloplasmin, and the INR is elevated, so that we're looking at patients who have synthetic defects, it may be a global problem. Very rarely we'll also have cases where you have a non-selective proteinuria or gut losing enteropathy, where we can lose proteins that are of higher molecular weight like ceruloplasmin. And so in those settings, you may unexpectedly see a reduction in the circulation of the protein. However, it's still that when you put that together with the other changes, the 24-hour urine copper, looking for the Kaiser-Fleischer rings if they're present, and then ultimately adding in liver changes with histology and or neurologic findings, and then ultimately the gene sequencing, you're actually starting to add in all the different elements, clinical, biochemical, molecular, that we put into what we call the Leipzig score that was developed back in 2003 as a consensus amongst experts. And this is a scoring system that when it's greater than 3 or above, that those are individuals who have a high probability of having Wilson disease, compared to when you do all the testing and you come back with a score that's 3 or under, it's probably not Wilson disease. You have to start looking elsewhere. There is some difficulty with certain other cholestatic diseases where you may have a falsely raised score. Great example that we published once had to do with a case of PFIC3, which had a lot of chronic cholestasis, high copper in the liver, and a high urine copper in that individual. But when you look at the ceruloplasmin, it was normal. When you do the gene sequencing, you actually then identify the defect for PFIC3 and not the defect in the ATP7B. So there are rare exceptions, but it is a very helpful scale to use when clinicians aren't sure.
That's great to know about having that tool. Is it, going back to diagnostic approaches, is there also imaging that you do routinely? And if so, what's your go-to imaging, or how is it helpful, I guess?
Well, the only imaging that's actually diagnostic for Wilson disease very specifically would be optical tomography, looking for the Kaiser-Fleischer rings. You can find suggestions in patients with neurologic disease that have brain MRIs that have abnormalities. There can be a tip-off that Wilson's may be considered based on often changes in the basal ganglia or in the pons that may be suggesting that this is Wilson disease, but it's not uniquely diagnostic, or similarly, the imaging of the liver is only going to reveal that you have changes related to advancing fibrosis over time. The copper is not paramagnetic, and you don't pick up any differences on MRI, so that's not going to help you directly for that. Now, there is an interesting, if you want to call it imaging, the PET imaging may actually be using radiocopper may actually be a way to diagnose Wilson disease, but that's right currently in research centers where that's being utilized, and what you find is a retention of the radiocopper within the liver that gives it a very high signal, and a lack of the biliary excreted copper owing to the underlying defect in the disease that doesn't give you that pattern of the copper going from the bile into the intestine over time. Or if you look in the blood, you can see the changes in the peaks of copper that might be incorporated into ceruloplasmin in the normal state are low in the patients with Wilson disease. But that's not a routine imaging methodology that we would use currently.
Right. Okay. So we've talked about the disease and diagnosis, and let's move on to treatment. What is kind of your first line treatment? I guess since I'm a focus on nutrition, I assume diet. A diet low in copper is one of the mainstays.
Well, I think we always, as physicians, and we often jump only right into the medicines that we use to treat. So I really appreciate your point of being careful about our dietary copper intake, and it's not just in our foods. We have to consider it in our water supply as well. And so if people are getting well water, it's very important to make sure those wells are checked and that they don't have copper or other heavy metals that are leaching into the system, because there are easily used filters that can take the metals out of that. The foods themselves, there are categories with very high copper foods. Examples would be certain shellfish like lobster in particular. And then you have dark chocolate, which many of my patients are very sad to hear. Mushrooms, legumes often can be very high in copper. And occasionally then people also seek out supplements, and everybody wants to have this wonderful supplement that's going to make their liver healthier. And unfortunately, some will contain high copper elements like those that have the blue-green algae as included in them. So you have to be very careful on that. But we consider the treatment part, and I'll get to the specific copper-directed treatments in a moment, have to look at the patient as a whole. So diet is definitely one of them. If a patient has a serious mood disorder related to Wilson disease, again, you shouldn't neglect treating that as well. So some of these patients benefit from interventions from our psychiatric colleagues, and depression is depression and anxiety are very common in population. And there also seems to be a slightly higher incidence of bipolar as well. And so that needs to be looked at independent. And even though we may treat, ultimately, copper-direct the therapy to try to improve it, we shouldn't neglect at the outset considering direct symptomatic treatment. Similarly, if a patient has very severe dystonia, some of the patients suffer from that as part of the neurologic symptomatology. They may have pain in certain areas or inability to move or control certain movements, fine motor movements. And so some of our movement disorder specialists can be very helpful, either in using systemic medications to increase muscle flexibility, or even doing localized therapy with botulinum toxin for very specific muscle groups. Even things like severe drooling, which happens in certain patients, they can actually use the botulinum toxin injections into the salivary glands to reduce that. So again, these sort of adjunctive treatments are important. Again, before we get to the therapy, one more thing is our liver patients. So if you have a patient with advanced liver disease and cirrhosis, you have to remember to do all the standard things we do for our other patients with portal hypertension. If they have varices, they're at risk. So we have to consider, either banding or non-selective beta blockers for them. There is a question about whether Wilson disease meets the incidence appropriate for chronic screening and then surveillance for hepatocellular carcinoma. I believe we probably should include it. We do all see over time a number of cases of patients who've developed liver cancer, and there's been rare cholangiocarcinomas as well, although we don't necessarily recommend screening for that by the stand like we would in a patient with sclerosing cholangitis. But if we do see abnormalities on testing, so imaging can be helpful in that light. Now let's get back to your basic question: is what do we do about medical therapy? And so when we look at patients, you have to remember there is only one medication that has a first-line FDA approval right now for starting people on therapy, and that's penicillamine. This is, I think, an unfortunate occurrence and more historic than anything else, how these meds came to be approved under the initial, the way they were at the time, coming under some of them came later under the Orphan Act and such, and didn't have the same process or ability to be put through testing head-to-head. And indeed, we only have one study where we have on chronic maintenance, which have compared head-to-head penicillamine to Trientine, an alternative chelating agent for copper. But that said, if we look at these things without the standard indication for that, I tend to look at things in a specific way. If a patient has symptomatic disease, and by this we mean either clinical symptoms or has inflammation and advanced fibrosis, when we start looking at the liver histologically, I look at those patients as needing more aggressive therapy. And those individuals, I believe we get to a faster improvement in our outcome if we can start with chelation therapy. Chelation therapy is penicillamine or Trientine. Both will move copper through the body and out in the urine, although Trientine has a secondary action by not being as well absorbed as penicillamine. Some stays in the gut, so it actually will block copper absorption as well as move copper into the urine. But on a mole-for-mole basis, you'll see more copper go in the urine with penicillamine because it is so well absorbed. Then we have what to do when we brought that patient who is symptomatic back into an asymptomatic phase or equivalent to that. And in those settings, we will use a lower dose of the chelation agent. Typically in the initial phase, it'll be up to 15 to 20 milligrams per kilogram for the chelating agents. And once we've achieved a more maintenance phase, when we've brought them back in better control, then we'll consider 15 to 10 milligrams per kilogram dosing of those medications. Now, we do follow the urine copper excretion in these patients, and it should start out high once you're on these chelating agents, again, being the mechanism of action, pulling the copper out of the bioavailable pool through the kidney into the urine. So we see extremely high levels, sometimes up to 1 milligram or even 2 milligrams of copper during the early phase of excretion. And then over time, we will see that go back down somewhere in the range between 1 and 500 micrograms in a day, which would be considered high compared to any non-affected individual. But for patients with Wilson's disease is kind of the range that we want to bring that into. Now, there are other options, and the other option is treatment with zinc therapy. This was first looked at as a different modality of blocking copper uptake from our diet. And in this instance, we give it as a multi-dosing per day. Zinc is not effective as a single daily dose in its current format, but it is effective in blocking copper uptake, and it works by creating a negative balance so that we have daily losses of copper in our secretions, whether it's salivary, pancreatic juices that go into the gut, or skin shedding, other tissue turnover. We will lose some copper normally. And so if your dietary copper is blocked, and that's our major source of replenishment, over time you go into a negative balance. It's just that it takes that little bit longer to get into the negative balance. And there is inexplicably a certain percent of people, it may be 5% to 10%, unclear, that actually don't seem to respond as well to the zinc therapy and don't seem to get as effective a copper block. So again, my another pearl to take is no matter which therapy you choose, look at what is going on in the patient after. So that sort of rolls into the monitoring part. But come back for 1 second to zinc. There is another area where some people feel more comfortable with zinc, and that's in the very early asymptomatic patient, recognizing that we don't have very good evidence base for a lot of studies using that as first-line therapy, and it's more accepted as a maintenance therapy. But in young patients who've had no symptoms at all, it is a consideration. In the chelating agents, there is always a concern, especially for penicillamine, where about 25 to 30% over a lifetime will either have initial hypersensitivity or later on develop other complications of using the medication, forcing a switch. We believe Trientine may have a safer profile, and we don't see as much from that drug. In zinc, the only systemic issue is a raising of the amylase and lipase, which is not associated with any clinical or any correlate on imaging of a pancreatitis. So it's really only a mild biochemical change that's really not very relevant for the most individuals. And then outside of that, the only issue is really dyspepsia. And some of that may be specific to the salt that the zinc is with, but up to about a third of patients who go on zinc therapy have that. In some cases, it can be very severe. And so we do have to counsel patients that if they are taking the medicine and not doing well with it, with respect to tolerance, and they can't do some of the workarounds like take protein with it, because protein won't block the absorption, whereas if you have bread products and grains that have phytates in it, it will block it. But they can take a little protein and they can buffer the zinc in. And if that still isn't working or trying a different zinc salt isn't working, then they really need to be back on a chelation agent properly. The key for the therapy, for all these therapies, it's a lifelong treatment. We have to have monitoring, make sure the patient is taking their therapy. Interruptions of therapy have actually, in some cases, recapitulated the setting of acute liver failure in some individuals. And so that is clear, or people who've never had any of the neurologic or mental health issues, and they were only hepatic originally, if they've stopped medicine, go on later to actually be susceptible to developing the extrahepatic manifestations as well. Now, one area I didn't mention so far was liver transplant, and where do we go with that? So clearly the patient, like you presented, that a 16-year-old with very severe acute liver failure, once they've crossed that threshold and they really have the encephalopathy and they really have the severe coagulopathy, these are patients that need to be evaluated right away. We can use things like the modified King score as well to look and try to prognosticate that individual. Are they going to really go on to need transplant, or is it somebody we might have a chance of rescuing with medical therapy? But once you have a score that's above 8 and you're 10 or more, and the patient is clinically, showing signs of instability, these are patients that we really need to move forward quickly to a transplant center for an evaluation and a transplant when a donor organ is available. There are things we can do to try to stabilize them, lower the acute levels of serum copper, which sort of is an outpouring as the liver is falling apart in these individuals. There's a tremendous release of copper into the circulation, which exacerbates the hemolysis, often can lead to acute tubular injury in the kidneys and shut the kidneys down temporarily. So there are reasons to effect some of these other measures to try to stabilize them while we're waiting for a donor organ. But let's assume we also have a patient who comes to us very late in terms of presenting with the chronic form of the disease. So a patient who has cirrhosis with very advanced portal hypertension and changes in their MELD score, and or PELD, if they're very young, more often it'll be they're sick like that, and it'll be a MELD score because the individual will be older. Those are individuals that also may benefit from transplant. There is a controversial area of transplant for patients with primary neurologic indication, and this has been promoted by a number of groups in France in particular, where organs seem to be more available, and they have tried to look systematically at this, but they've never done a controlled study where we've looked at medical therapy versus transplant in the outcome. The part of that that is difficult is that none of the bad outcomes are ever published. And rare cases happen. And the Italian group a number of years ago was very honest and showed that a number of their severely impaired neurologic patients didn't improve and had complications, including sepsis, post-op, and their survival was less than optimal. And we all hear of the cases or know that sometimes if you take a patient who is truly severely incapacitated and has injuries that probably are not reversible, and these are the ones, and this is the only other time I find imaging helpful. If you do a brain MRI and you see a lot of cavitation and severe changes in the brain, those are patients where you really worry that even if you transplant them, that may not get better, nor will it necessarily respond well to medical therapy either. But again, organs are a precious commodity, and so we want to use them well, and we don't want to put a patient who's not going to do well through a whole process like that as well too. But there are select cases and where people believe there has been some benefit. And if you look at people who are failing medical therapy in terms of having progressive neurologic change despite 3 to 6 months of medical therapy, then I believe it's reasonable to consider, although I wish it were in a controlled study and not one-off kind of cases, because it does take 3 to 6 months often of a lot of good intensive care to take those patients who have advanced symptomatic disease to get them to respond. Now, one area I haven't touched on is some of the advances in monitoring. So we've been focused often on liver tests and normalization, or at least bringing them in the direction towards normal, improvement in coagulation, looking at symptomatic improvement individuals, looking at urine coppers going into range for the particular therapy. And so those are good parameters, but they're not perfect. And they also will not be the best canary in the coal mine for telling you when your patient is going to start getting in trouble. So there's been a move recently to start looking at ways of looking at that bioavailable copper in the circulation. And we know that symptomatic patients, when they present either with neurologic disease or very advanced liver disease, often have a higher amount of the bioavailable copper present in the circulation. And you can look by a couple of different methods. In Europe, it's often done by the centrifugation method, where they then look at what's in this low molecular weight part of the centrifugation of the serum after treatment with EDTA. So it's extractable copper. That's where the term exchangeable copper comes from. And there's an alternative method that's been developed as well, using column chromatography to separate and speciate the proteins in the circulation and then determine the copper in the individual peaks. And if you can isolate the peak for ceruloplasmin, which can be done using anion exchange chromatography, you can use ICP mass spectroscopy to then go and measure the copper very accurately. So we can start to get closer to looking at what we call that non-ceruloplasmin copper, or the bioavailable copper. We know it's high in these symptomatic patients. We know it's high at the onset in most naive patients. What we don't know officially is the perfect ranges for these yet. This was used as a marker in this study called the chelate study, the one that treated patients with penicillamine to either stay on penicillamine or be treated with Trientine tetrahydrochloride. And in that study, the non-ceruloplasmin copper by the speciation method was used as a primary endpoint. And we saw that the two medications were very good at keeping that at a lower level, although there were differences in the urine copper excretion, which is expected based on the different way the particular medicines are absorbed and how they work. So we think that looking at that, and if we can understand best where the ranges are supposed to be in treated patients compared to normal. Now, for years we thought when we started looking at this, we were going to see the same thing as in a normal individual, about 10% of the copper in circulation being bioavailable. But actually, when we started doing secondary analysis in the chelate study, and since in other patients have been looked at using the exchangeable copper by groups in Barcelona and then France, and what they found is that they saw the lower the level, below that 10%, where we had theoretically thought it would be in a normal, was associated with better biochemical parameters in the liver patients. Now, is that associated with better outcomes? We think it might be. We don't have the data yet to show that. So that kind of validation hopefully will be forthcoming. And when we have that, that'll be the opportunity to, well, first, our patients will be very happy if they can lose the 24-hour urine collections and just do a simple blood test. But more importantly for us, the variability in the urine copper sometimes makes us use multiple parameters. But here, this may be the one biomarker that'll tell us time to raise your therapy in terms of the amount, or time to lower your therapy to then go on to prevent the development of a relative copper deficiency by overtreatment in some of these individuals. So we hope that'll be forthcoming in the near future. There are potential new things in development for that hopefully will accelerate that.
It sounds like a lot of exciting new developments. Speaking of, I guess my last question is there a work being done in terms of gene, therapy as a potential cure, or?
So there were 2 trials that were launched in, I think, 2020, 2021 for gene therapy using adeno-associated virus-mediated transfer of mini genes for ATP7B, the mini being that they had to be truncated a little bit so that they'd fit inside the payload of the viral vector to deliver it into the liver. One of the studies, unfortunately, has been suspended due to not achieving the ability to show significant changes in the copper parameters despite the transduction in the liver. And so further study of that is ongoing. There's another ongoing study being conducted by Ultragenics still, using slightly different, it's another adeno-associated virus with, again, another truncated ATP7B gene that is being delivered, and we're eagerly awaiting to see what the results of that trial are. Those have not been released as yet. Very exciting, though, is the potential development for gene repair. And there's been some nice data that has been presented at the American Association Study for Liver Disease meeting back this last November 2024, in which they showed the repair of the most common defect, the H1069Q, in the animal models and in cell models without off-target effect using this prime editing methodology. And so this is something that is very exciting, and they delivered that using not viral mediated transfer. It was transferred using lipid nanoparticles that were taken up via the acyl-glycoprotein receptor, which gives you a high specificity into liver cells. So that is something we hope we'll see moving forward in 2026. There's, other exciting things. There's new compounds, novel compounds like methanobactin, which may have the ability to push copper out of the liver, but that is still in development as well. So there are new things on the horizon for us.
Sounds like a lot of exciting things to come. Look forward to hearing more about those developments. So thank you so much for being with us today and sharing your knowledge and all the great work you do for patients with Wilson disease. So
thank you for the opportunity.